Om Swastiastu. Good morning, doctors and friends. Today, Group B7 will discuss about supracondylar fracture in children. Please enjoy.
Hello, my name is Nanda Pramesti with student number 167. Now I'm explain about our background in supracondylar fracture in children. In the pediatric population, often the outstretched arm is used as a protection to prevent falls. Of course, these events are the cause of cases supracondylar fracture distal humerus in children. The percentage of supracondylar humerus fracture account for 18% of total pediatric fractures and 60% of elbow fracture that require hospitalization. Those aged 5 years or an average for about 6 years experience the same type of fracture, and both with men and women. The incident ratio was the same. Case reports suggest that 97% to 99% of cases are extension tape fracture due to the posterior medial displacement of the distal humerus and are associated with both radial and median nerve injury. The tendency for the distal humerus to be traumatized is due to the weakness of the anatomical structure connected by the thin bones. A comprehensive examination is very important in order to avoid complication about the integrity of the soft tissue covering it and the patient's neurovascular status. On physical examination of the injured arm, there is a swelling and shape deformity, and if the injury is more severe, there may be sign of wrinkling in the patient's antecubital fossa. Of course, this complication cause disruption of children's cosmetic or appearance in their life. Therefore, with the student project, as a form of our attention to supracondylar fracture in children, we will explain in detail about this incident and other factors involved. And research question: what is the supracondylar fracture? 2. What is the epidemiology of supracondylar fracture in children? 3. What is the etiology of supracondylar fracture in children? 4. What is the classification and anatomy of supracondylar fracture in children? 5. What is the diagnostic criteria of supracondylar fracture in children? 6. What is the prognosis and complication of supracondylar fracture in children? 7. What is the management for supracondylar fracture in children? And the purpose of the research is same with the research question. And the benefit of the research is, with our student project, can improve the understanding of medical students in studying the case of supracondylar fracture in children, and also the knowledge in dealing with the supracondylar fracture in children can be applied case in the future. Thank you.
Good afternoon, doctor and friends. My name is Pratista. My student number is 227. So now I'm going to explain about the definition of supracondylar fracture. Supracondylar fracture are the most common fracture in children and occur in the distal humerus or femur above the level of the condyles and epicondyles. Supracondylar fracture most commonly occur in the upper limb region in children, specifically distal to the humerus proximal, to the trochlear and humeral capitellum, with fracture line running through the coronary fossa and olecranon fossa.
Hello, my name is Dara Cynthia Augustine with my student number 069, and I would explain about the epidemiology of supracondylar fractures in children. Supracondylar fractures, especially of the humerus, are the most common fractures in children and the most common pediatric fractures requiring for surgery. Supracondylar fractures of the humerus represent a significant burden of injuries in children, accounting for about 12 until 18% of all pediatric fractures and 95% of extension injuries. Supracondylar fractures of the humerus have a peak incidence at 7 years of age, both males and females, and boys outnumber girls by about 3 times in incidence of supracondylar fractures of the humerus. Most studies reported that male predominance and attribute this to physiological influence of hormone at puberty, where boys would be more adventurous and would be more likely to participate in risky physical activities. So that's all from me. Thank you.
Okay, my name is Sarah Prabu, this is number of 253, and I will explain about the etiology. So, supracondylar fracture in post-trauma is the cause of mortality, morbidity, and disability, leading on to socioeconomic burden. Commonly occurs in the pediatric population with the number of 18% of pediatric overall fractures between children aged 5 until 10 years old. 60% of elbow fractures, 70% of patients report the injury after a fall, and it happens in outdoor environments as the number has shown is 71%. So the distal humerus is composed of medial and lateral columns, trochlea, and medial epicondyle medially, and also capitellum and lateral epicondyle laterally. The distal humerus narrows proximately from metaphysis to diaphysis and tends in the anteroposterior as the medial lateral columns merge at the proximal aspect of all cranial fossa, creating a weak point that can withstand the force of a fall, causing fractures. Thank you.
Hi, my name is Patrindria and my last 2 number is 200, and now I'm going to talk about the pathophysiology of supracondylar fracture in children. So this type of fracture usually happens when a children fall from a height and cause a hyperextension of the elbow. So the fall is usually on an outstretched arm. So the anatomy of the distal humerus is quite weak. It is caused by the fact that the configurations between the 2 bones are connected by a very thin bone. And in this condition, i.e. the supracondylar fracture, the olecranon attracts the olecranon fossa and creates a force to the distal humerus, thus cause the supracondylar fracture. Supracondylar fracture can happen both anteriorly and posteriorly. That's all I can say about pathophysiology. Thank you.
Good morning, Dr. and friends. My name is Putu Andrea Wisnu Bastian with student number 143. So I'm going to explain about anatomy and classification of the supracondylar fracture. There are 2 main points of anatomy. The first is the bones. The supracondylar region is a weak and thin area that located in the distal of the humerus. This area is bordered by coronate fossa anteriorly and olecranon fossa posteriorly. The second is the soft tissues that correlates with the supracondylar fractures, which consists of the first is the muscles that have a role in the displacement and rotational of the distal segment, and the second is the neurovascular injury that consists of brachial artery that located in the anteromedial of the distal segments, and major structural of the neurological, which consists of ulnar, medial, and radial nerves. The classification consists of 2 types. The first is depending on the movement of the distal segments, which consists of 2 types. The first is the extension type, which is the commonest type in children and caused by hyperflexion injury. The second is the flexion type, that is the rarest cases and mostly caused by the direct violence that cause the flex of the joints. The second is the modified guideline staging system that consists of 4 types. The first type is the undisplaced. The second type is the incomplete displacement with angulation. The third type is complete displacement with posterior periosteum intact. And the lastly 4th type is the periosteum ruptured with the flexion extension is unstable.
Hello, doctors and friends. My name is Zaki Arafi Aidi with student number 122. There are several signs of supracondylar fracture that could occur after an incident, and all of these signs and symptoms can be evaluated by physical examination. The symptoms include pain in the elbow, extensive ecchymosis, soft tissue swelling in the elbow and hand, obvious deformity of the elbow or arm, puckering, elbow disability due pain, numbness in the finger and hand, and fingers or hand of the injured arm are cold, cool, or blue. That's all for today. Thank you.
Hello, my name is Dino Sowatama Sriringo, student number 045, and I'm going to explain about the examination for diagnosing supracondylar fracture in children. For the clinical presentation, we will find a painful swollen elbow that the patient is hesitant to move, including a history of high energy trauma or full complications. Urgent orthopedic review in emergency department should be done if there is absence of radial pulse, ischemia of hand, severe swelling in forearm or elbow, skin puckering or anterior bruising, open injury, and neurological injury. For the radiographic examination, we will get anterior-posterior view and lateral view of the elbow or any other sites or of deformity, pain, or tenderness. Thank you.
Hello, my name is Mani and the last digits of my name is 249. So today I'm talking about complications and prognosis. For complications, managing peripheral nerve pulse is often challenging due to the difficulty in obtaining a reliable clinical examination in the emergency setting. It is important to provide explanation and reassurance of the parents regarding the very likelihood of the recovery of the nerve. For the second part will be the prognosis. Close reduction remains the first approach for this type of fracture. Nevertheless, if open reduction is needed, controversy does exist regarding whether it causes a decrease in range of motion and an increase in other complications as well. Furthermore, the timing of the surgery and the effect of delaying operative treatment has been underlying investigation previously and that has not led to any definite recommendations to date. In addition, for the last part, the experience of the surgeon as well as the duration of the surgery may affect the outcome of the operation. Thank you very much, and my friend will continue the next part.
Hello, my name is Shantika Plia Rahmawati with my student number 106, Management of Supracondylar Fractures. There are different management of each type of supracondylar fracture. In example, type 1 can be treated with immobilization using a splint or circular cast with 90-degree flex elbow. In type 2, bone reduction consists of placement of long arm cast with close follow-up and CRPP. In addition, type 3 fractures treatment consists of close reduction and percutaneous pinning. However, in the presence of vascular compromise and compartment syndrome, emergent intervention such as open reduction is essential. Besides that, that's also emergency method and pain control. For the close reduction, in the case of supracondylar fracture in child, close reduction should be the priority management. There are various techniques to do this method according to the type of supracondylar fracture which patients have. On the certain type, close reduction seems to be easy, safe, and reliable with a low risk of complication. An example, on the type 1 and 2, close reduction can be helped to get better stability. On the other hand, close reduction can be applied if only soft tissues entrapment, closed hand remains without perfusion, and vascular injury are not found when the surgeon do the observation. So that it's become a challenge of this method, especially on the type 3 and 4. In recent studies, it said that the surgeon need to consider close reduction because it has high risk on the neurovascular injury, and open reduction can be a better management option. Thank you.
Hello everyone, my name is Turjo Kusasi with last register number 021. So I'm going to explain about the open reduction and emergency and pain control in supracondylar fractures. Supracondylar fractures are usually reducible by close reductions. However, open reduction is indicated when supracondylar fractures is irreducible with close reduction, vascular compromise, open fractures, and if intraoperative imaging facilities is not available. Approaches of open reductions in supracondylar fracture surgery include anterior, medial, lateral, and posterior approaches. Anterior and anteromedial approaches are used for posterolaterally displaced fractures associated with vascular compromise and median nerve injury. A medial and lateral approach are decided based on where the peristome is stored. In addition, posterior approach is not recommended because this approach may harm the blood supply to the distal humerus. As soon as reduction has been achieved, cross-Kirschner wires is recommended for fixations. And here is the figure of supracondylar fracture reduction followed with percutaneous pinning or K-wires. So the next one is emergency methods and pain control in supracondylar fractures. Emergency methods that can be applied to control the pain and avoid neurovascular injury include immobilize the elbow with a long arm splint at 30 to 40 degree of flexion until surgery is performed, doing physical examination and regular monitoring carefully, avoid neurovascular injuries and minimize the risk of compartment syndrome, keep the elbow above the heart level for 48 hours after the cast is put on, and the last one is little movement on fingers may help the blood flow to the fingers. Thank you.
Hello guys, my name is Putra Binamasaranardika with student number 239. Now I'll give you the conclusion for this research. So supracondylar fractures are the most common fractures in children between 3 till 10 years old, occur in the distal humerus or femur above the level of the condylus and epicondylus. Supracondylar fractures, especially of the humerus, are the most common fractures in children with 12 till 18% of all pediatric fractures and 95% of extension injuries. Supracondylar fractures commonly occurs in the pediatric population in children aged 5 to 10 years old, up to 18% of pediatric overall fractures, 60% of elbow fractures, 70% of patients acquire the injury after a fall on the outstretched hand, 71% occurs in outdoor environments. There are two main classifications of supracondylar fractures depending on direction of the fragment displacement. These two types further divided into 4 types based on the modified Garland staging system. There are many symptoms to diagnose supracondylar fracture such as pain in elbow, intensive ecchymosis, soft tissue swelling in the elbow and hand, obvious deformity of the arm or elbow, puckering, elbow disability due to pain, numbness in the fingers or hand of the injured arm are cold or blue. There are three management of supracondylar fracture such as close reduction, open reduction, and emergency method and pain control. So that's all about conclusion for this research. Thank you.
That's all from our presentation. Thank you for your attention, and we close it with Paramasanti. Om Santi Santi Santi.